Good morning, and welcome to our session on clarifying myths and challenging biases about race and research review. My name is Jada Bussey-Jones. I'm a professor of medicine and vice chair for the Department of Medicine at Emory School of Medicine. I'm also the chief of Journal of Internal Medicine and Geriatrics based at Grady and assistant dean for professional development. I am delighted to be a part of this excellent and informative session. We have some really great speakers for you today that will both define the problem and talk about potential solutions. I'd like to introduce our speakers, which include Linda Coleman, who is a director of Human Research Protection Program at Yale University and has served in this capacity since 2016. Before she joined Yale, she held several positions at Quorum Review, which is an independent IRB. Linda Coleman served as the Quorum's Vice President and Regulatory of Legal Affairs. She is also actively involved in several professional organizations and is a member of the DHHS Secretary's Advisory Committee on Human Research Protection. Some of her areas of expertise include IRB harmonization, decentralized clinical trials, common rule and IRB implementation strategies, research data protection, clinical trial process improvement, research quality and compliance, and the use of technology and research. She is also frequently presenting on a variety of topics that include operations management, research integrity, good clinical practice, research oversight, and operationalization of regulatory and institutional requirements pertaining to research and global bioethics. We also have Glenn Ellis, who is a medical ethicist, a researcher, lecturer, and president of the Strategies for Wellbeing, LLC, which is a global consultancy that specializes in health education, equity, disparities, advocacy, policy, and communication. He is also a visiting scholar at the National Center for Bioethics Research and Healthcare at Tuskegee University. And he is a bioethics fellow at the Center for Bioethics at Harvard Medical School. Mr. Ellis is particularly interested in the ethical protection and rights for patients in medical care and clinical research. He has authored and co-authored several papers, including in journals of the American Journal of Public Health, the American Journal of Academic Medicine, and several others. He's also the author of Witch Doctor and Information in the Best Medicine. In addition to a weekly nationally syndicated health column, Mr. Ellis also hosts a weekly public health program on Philadelphia's WURD radio. So it is with my great pleasure that I begin by introducing Mr. Glenn Ellis, who will be followed by Ms. Linda Coleman. Thank you. You're muted, Glenn.
How about it? Let's try that again. I wanted to just first just say thank you, Dr. Bussey-Jones, for that generous introduction, and I'm grateful to be here, and certainly with this distinguished colleague, Ms. Linda Coleman. It's grateful to be here. I am going to try to make some points through my presentation. I'm going to share my screen, and I would like to just go through some information that I think may be helpful for us to understand how to really begin to wrap our hands around this topic, which is a very difficult one. So we're here today as the topic and the title of this session is clarifying the myths and challenging bias about race in research review. So first, I want to make sure you know I have no relevant personal, professional, or financial relationships with respect to this activity. And Dr. Bussey-Jones gave you all that I'm sure you care to know about my background. So let me just start by saying what I like to talk to you about today are the kinds of things that I think are relevant to inform the type of solutions that are going to be required for us to truly address the inequities in clinical research. So a part of this informing process means that I have to, as this quote says, I'm the storyteller on behalf of the lion. because until the lion gets its own storyteller, the story of the hunt will always glorify the hunter. So we want to bring more information. And as Maya Angelou, Dr. Angelou would say, you can't really know where you're going until you know where you've actually been. And often many of us have not really had the ability, opportunity, or the fortune to be able to truly understand the history behind a lot of these inequities. We can start by just looking at what we know thus far as has been revealed through this pandemic about what has happened with this particular virus, this pandemic, and the Black community. We also have seen how it has resulted in a system which is probably the best and the most expensive medical and healthcare system in the world at a time like this, that a segment of the population, Black Americans, have not had adequate access to testing as well as the actual medical care in the midst of this pandemic. This is reflected when we look at the data, not even looking at this pandemic, but data from the FDA going back 2019, prior to the pandemic, and look at the dismal types of participation of particularly Black and brown communities in clinical research. And so the question is, why is this? Why are we underrepresented in research? We know that there's evidence to show that Blacks are viewed by many medical professionals as just being too challenging to get involved with, and that we therefore are seen as less promising research participants. We are documented to have all of these comorbid chronic conditions, and we're not asked to even participate most of the time. So it's just simply put, we are excluded from research, and there's no question about that. So we failed as a research community, African Americans and Black Americans in this country, Black and brown people. That means as scientists, as researchers, we're not doing good science. We've seen this reflected over and over and over, and most notably when we look at the study in the Blood Journal for the American Society of Hematology that clearly demonstrated that even though Blacks are significant parts of the population of people who are affected by multiple myeloma, the research only included 2% of patients who were Black. So we're not even doing good science. So it's not just about the right thing to do and equity and social justice. We're not doing good science. So as a result of that, particularly for Black and brown people in this country right now, this is deja vu all over again. Right now, after 40 years of research on drugs and vaccines for HIV/AIDS, HIV/AIDS is now a chronic condition in white America, but it's still an epidemic in Black and brown America. And this is not just about Tuskegee. With all due respect, where I'm currently a visiting scholar at the National Bioethics Center, but we tend to want to just put all of this blame on the mistrust that grew out of Tuskegee. But this is far deeper and has a much longer history about it. We have a legacy of mistrust, and that are just too numerous for us to really go through here. But as far back as 1800, when Dr. J. Marion Sims was performing gynecological surgeries and explorations and creating him a reputation of being the father of gynecology by doing it on enslaved Black women and girls without their permission and without anesthesia. And the atrocities go on, and they go way back. So far back that Dr. Ronna Hogarth at the University of Illinois in Urbana actually documented this in her book to show how just being Black became a medical condition. So it lent itself to what we now see, where Blackness and mistrust are almost like medical conditions, like psychological or psychiatric conditions. Even before that era on plantations, there was also atrocities and research conducted on the ships that brought enslaved Africans over here. In 1787, Thomas Jefferson, who was trying to extol the virtues and the brilliance of the state of Virginia, wrote a booklet, a little pamphlet called Notes on Virginia. And he made a passing comment that was really critical of the lack of higher productivity of enslaved people out in the tobacco fields. He made a comment and said that there was a difference of structure in the pulmonary apparatus, meaning their lungs were not as good as white lungs. Out of that grew the spirometer and so many other things that use race correction, that we still to this day are still using race correction in the spirometer, along with the GFR and so many other things. And there is, this list reflects, there's a litany of other types of examples throughout the entire field of medicine where race correction is still used in 2020. Understanding that race is a social construct, and yet here we are as scientists and researchers still applying race in the context of science and medicine and research. We have algorithms used in hospitals today to determine who gets follow-up care. But the algorithm is based on healthcare spending and not need. So as a result of that, only 18% of the people who were identified by this algorithm as needing more care were Black, compared to 82% of white patients. Now, if this algorithm was an equitable one that truly looked at the need for outpatient care, those figures would have been 46% for Black people and 53% for white people. But instead, we end up with an 18 to 82% proportion. I want to point out how important it is to understand the Lion's story. This is a picture, an iconic picture of the Black Panther Party that many people are either know about or have seen. And they have been categorized. This is a militant revolutionary organization in the late 60s that wanted to overthrow the government and have a revolution. But what nobody understands is that the formation of the Black Panther Party grew out of them creating programs to address sickle cell anemia and sickle cell disease in Black communities that had been totally neglected by funding and other care systems in our society. So they started clinics. They also opened free breakfast programs at schools for children and medical clinics. And here we are in 2020 today, another example where Black doctors are actually doing the testing in church parking lots on weekends after they get off work. So what do we have to do in order to really look at how to recruit and how to retain participants of a diverse basis? All we have to do is do what we've never done. We have to have focus groups. We have to include viewpoints of the participants. We have to engage those participants. We have to actively, and I mean actively, recruit and increase our numbers of African-American principal investigators. And then we have to actually follow and hold accountability to the federal laws that currently exist that we have not, up to this point, demonstrated any accountability. So as researchers, we must never lose sight of our mission, of our work as a research community to improve the quality of life for all. Thank you very much. And I now will ask you to devote your attention to our next speaker, who is Ms. Linda Coleman, is going to bring you some information about some strategies that are being applied now.
Okay. Thank you very much, Mr. Ellis. Perfect. So, can everyone hear me okay? Perfect. All right, I'm going to now spend the next 15 minutes or so providing an overview of Yale's approach for promoting diversity, inclusion, and research. And followed by my presentation, we will have an opportunity for all of us to come together to answer some of your questions. So this is my disclosure. I have no relevant personal, professional, financial relationships with respect to this educational activity. And we've already gone through my bio, so I won't go into that. So I'll just start here. So central to the discussion is the interrelationship and importance of the Human Research Protection Program, the IRB, researchers and other institutional offices, partners, collaborators, in regard to ensuring diversity, including inclusion of underrepresented minorities in research. Community partnerships, which should represent diverse population groups based on age, gender, socioeconomic status, race, ethnicity, limited English language proficiency, and others are central to progress in this area. And all are critical and an important part of the conversation at each stage of the research life cycle. And so what I mean by that is study development, like feasibility. I know all too often we focus our attention on budgeting and operationalizing research, but really at the time you're developing a study, some of these types of issues need to be looked at before you submit to the IRB, when you submit to the IRB, how the IRB evaluates the study, how a study is being activated, like recruitment, how a study is being conducted, closeout, and dissemination of results. All of these things are critical, and each stakeholder has an important part in that conversation. So before I turn to the specifics regarding Yale's approach, I thought it might be good to, let me just back up here for a second here. I'm having some difficulty with my slides here. I thought it'd be good to review some basic demographic information regarding where Yale University is located. So New Haven, for those of you who don't know, is located in Connecticut. And if you've not been to Yale, it's not a very large city, but it has about 131,000 residents, and it's the third largest city in Connecticut. Hartford and Bridgeport are larger cities. The average household income in New Haven is around $63,189, and the poverty rate is around 26%. And there are a fair number of homeless individuals in the city. What's really interesting, though, about New Haven is some of the neighboring towns have much higher median incomes and much lower poverty rates. Many are well below 5%, like closer to 1%. I will say, however, that Hartford and Bridgeport, being larger cities, appear to have similar numbers as New Haven in regard to the average household income and poverty rates. So based on this slide, I pulled a report, let's call it from citydata.com. It's a New Haven report from 2018. And essentially, it breaks down the races as follows. So in New Haven, there are 34.5% Black, 30% white, 29.3% Hispanic, 4.7% Asian, 2% identify as two or more races, and 0.4% are considered other. Note, however, that being Hispanic is not a racial category, as someone in this group may be of any race. They could consider themselves white, Black, or another race. In regard to languages, there are many spoken in New Haven, but English is the most prevalent, 72.9%, and Spanish is second at 22.9%. And according to the New Haven, the Yale Language Center, there are more than 60,000 languages spoken among 27,000 students, which obviously present challenges and opportunities for New Haven and the public school system. So this slide just kind of shows you a list of some of the languages and the diversity in the city. I also wanted to point out that I found some statistics that showed that 85% in New Haven have a high school diploma or higher, and around 35% have a bachelor's degree or higher. The next three slides I'm going to go over are going to, I'm going to discuss Yale's clinical footprint. And we're going to talk about this because it's going to be important for understanding Yale's recruitment strategy for its clinical research and why it has been successful in recruiting traditionally underrepresented groups. So on this slide here, this shows some of the various locations regarding where Yale New Haven Health System and some of its affiliated clinical sites are located in the state of Connecticut. So the Yale, just by way of background, the Yale New Haven Health System is a separate legal entity from Yale University, but many Yale researchers are affiliated with the hospital system. On the top left is Yale New Haven Health in Greenwich, followed by, next to it is Yale New Haven Health System in Bridgeport. And there are also locations, obviously in New Haven, like our Smile Up Cancer Center, our Children's Hospital, and there are a number of other groups, a number of other clinics in surrounding communities. Demographically, many of these hospitals and clinics are located in areas that are very different demographically. For example, Greenwich is a quite affluent community, whereas Bridgeport and New Haven, as I've mentioned, is very diverse and has higher poverty rates. This slide here provides, this information here is based on 2018 data and will give you a sense of the volume of clinical encounters and some other really interesting information. So for example, it gives some information regarding the number of emergency room visits, inpatient admissions, number of beds, the number of staff employees, the amount of research funding received, and a number of active studies at Yale. And this is a little bit more detailed information, if you're interested, that looks at the various clinical locations. So based on this data, you can see that Yale New Haven Hospital, which is in New Haven itself, has the most licensed beds, has the most inpatient, outpatient encounters, emergency room visits, medical staff, and employees. So the reason why we're talking about this is I'm going to be focusing a lot on Yale's recruitment efforts. And I know there's many things we could probably talk about in regard to how we can ensure diversity in research, but I'm going to focus a little bit on recruitment strategies. So by leveraging our electronic health record footprint throughout our Yale New Haven Health System, which I just outlined, Yale has been able to develop an integrated and centralized recruitment strategy, which has really helped increase diversity in research. So launched in 2010, Help Us Discover is the name of the program, is a project which includes a robust clinical awareness campaign. It was designed by the Yale Center for Clinical Investigation, which is called YCCI, and it was done in collaboration with the Yale New Haven Health System, which I just outlined for you, researchers, community leadership, we call them the cultural ambassadors, and I'll talk about them in a moment, and various Yale University offices, such as our privacy office, our human research protection program, the IRB, Yale School of Medicine, as well as others. The Help Us Discover project is IRB approved. So what's interesting about this is we are looking at recruitment from a more programmatic level, and so it is IRB approved. It gets reviewed annually, reviewed and approved annually, and there have been a fair number of changes made over the years to improve the process. So Help Us Discover has a number of purposes, but its primary objectives are to assist researchers with recruitment, to create a centralized recruitment registry of volunteers. It's meant to engage the community regarding research and healthcare, I would say, and to increase diversity in clinical trials, which would include including the inclusion of historically underrepresented populations. The database of research volunteers is an active process in which persons agree to create a research recruitment profile and be informed when research relevant to their profile is recruiting. And so persons are invited to enroll as volunteers through extensive media and announcements and through specific website listings of active studies. There is also a robust educational and recruitment outreach program, which uses flyers, brochures, billboards, paid advertisements in local media, such as newspaper, radio, and TV. We also have a number of special events like Volunteer Appreciation Day, and there's also a website. So this slide just sort of gives you a kind of a snapshot of, some of the individuals that have been very involved in this process. There is a second method for recruitment, which I'll talk about a bit, and it's called engagement enrollment, and it's through EPIC and MyChart. So unlike the volunteers who take action to join the registry, participation through engagement enrollment is automatic for all patients who receive care at a Yale New Haven health system, unless the patient chooses to opt out of participation. So by extending enrollment to all patients, it extends the benefits of receiving information about ongoing trials to a wider audience through automatic enrollment. It enhances recruitment efforts and assures a subject-based representative of the Yale New Haven community. And what I wanted to say, and I want to emphasize, is that our cultural ambassadors, and I'll talk about them in a moment, which includes church leaders, members of a nonprofit organization called Junta, and others, are central to the success of these methods for recruitment, and they were very instrumental in helping to design this entire program. And I also will say that the Human Research Protection Program and the IRB was very much involved as well, going way back on this global initiative. And of course, when studies are reviewed, they also review individual studies in regards to recruitment strategies as well, to ensure that they're following all of the guidelines and processes that were put in place and protections that were put in place as part of this global or programmatic strategy at Yale. This slide here, I wanted to share, is uses MyChart. It was called MyChart. And so the title of the slide says leveraging MyChart patient portal for research and direct-to-patient messaging. So it's a little bit difficult to see here, but when a patient logs in, the patient can access research information by selecting a research tab, and patients can search clinical trials, build a profile, sign up for trials, and opt out of research altogether. And statistically, let me see if I can move this forward a bit here. Twice as many participants are recruited for research studies using MyChart than through traditional advertising or traditional methods. There have also been significant numbers that have consented to studies, and even in situations where a potential research participant may have failed screening, many were ultimately enrolled in other studies. So this is sort of what we call the halo effect. So there's some statistics here if you're interested in understanding that a bit more. Another important thing to consider is this, in terms of MyChart direct to patient, is business and after hours and how important that is. So what we learned over the years by analyzing data regarding the Help Us Discover project or program is that a significant number, as high as 30, 40, almost 40%, express interest or respond to inquiries regarding research after traditional business hours. And a review of the data also found that 57% of minorities versus 38% of non-minorities responded after hours or on weekends. And I think this is really important because it shows that research sites, not just Yale, should consider engaging potential and enroll participants outside of normal business hours, or at least provide some options for after hours or weekend work so that it does not disproportionately impact individuals. This slide here is a little bit difficult to read, but it kind of illustrates, it gives you a timeline that illustrates some of the steps that were taken to engage the community in regard to innovation and recruitment of diverse populations. And so since 2010, there have been countless focus groups, campaign planning sessions, community meetings regarding opt-out, meetings regarding the consent forms, recruitment, research scope, dissemination of results. There have been also collaborations with sponsors and other institutions and community groups, and these efforts continue today. So what we have found is that in addition to having buy-in from our institutional leadership and engaging all the various offices as part of this process, we have found that the Yale's Cultural Ambassador Program has been crucial to the success of Yale's recruitment strategy. And so Yale considers the work it does with the cultural ambassadors as a bidirectional collaboration. It's not just as simple as just inviting individuals from the community to a few meetings and having some general discussions. This is truly a bidirectional collaboration. It's a way for the cultural ambassadors to express community needs, ideas, and interests, not just with respect to research, but with respect to healthcare. It's a way to provide recruitment campaign development advice and recruitment support for special populations. It's critical for study design support and advice to researchers and the IRB when questions arise early on in the process and later on in the process once a study is submitted to the IRB for review. Our cultural ambassadors also support translations of study material. Junta is an organization I mentioned earlier, and they do majority of our Spanish translations. And so this is a win-win for the community in terms of having them participate in that process. The cultural ambassadors also participate in community grand rounds that are held monthly and are involved in countless other activities. This slide here just kind of gives you an idea of the community's priority list. It's a fairly long list. This was from 2018 to 2019, which really lists a number of things in terms of issues related to access to healthcare, addressing health disparities, violence and crime prevention, cancer care, violence and crime prevention, diabetes, mental health issues, etc. And then the work is constantly reviewed. I mean, it's regularly reviewed throughout the year. So for fiscal year 2020, some of the work was reprioritized to focus on, like, for example, cardiovascular disease and health, such as heart failure, hypertension, obesity, diabetes prevention. They also had a reprioritizing work with respect to focusing on prostate cancer. There's also the FDA partnership. We have a memorandum of understanding with the FDA, which I'll discuss in a moment. And then mental health issues, including depression and substance abuse as well. This is, I mentioned earlier, the FDA partnership with Yale. And so there's a link here if you're interested in looking at the MOU itself. So the types of initiatives expected to develop from this MOU include, but are not limited to, a number of things. And that includes collaborations to cultivate and advance the Yale Cultural Ambassador Program and the engagement of community partners, to increase participation of diverse and historically underrepresented or underserved populations in clinical research. A couple of other points, I'm focusing much more on recruitment for the purposes of this presentation, but another piece that's important here, and Mr. Ellis mentioned this, is advancing education and participation of diversity of health professional and scientific workforce in health and biomedical science research, including clinical trials. And then a third is advancing student education and matriculation into the health and biomedical science professions. And there's a longer list in the document itself if you're interested in looking at that. But I just want to point out that you know it goes beyond recruitment in terms of trying to address some of these issues. In regard to COVID, there was a lot of early community engagement in terms of how we're going to address this crisis. So early on, and it basically affected the New Haven, Connecticut area in March, April, and May, and there were countless. There are many conversations with our cultural ambassador representatives, weekly meetings with our Yale Center for Clinical Investigation, Yale School of Medicine, the hospital system, the IRB. There are multimedia campaigns, including a radio community access programming, and everyone participated, even despite the fact that everyone's used to getting together in person, and we were able to meet remotely. And this slide here is just a picture I was part of this. We have something called the Tom Ficklin Show, and there was a researcher that was doing some research on pneumonia prevention. And so we had a number of, there were several pages of individuals that were part of this conversation, but we met to talk about the study, talk about the science, talk about some of the issues for the community, and the group was very engaged in this process. So what I wanted to mention here is members of, I attended as representative from the Human Research Protection Program. We also had one of our IRBs attend along with the researcher and research staff to talk about this study. And so this was done early on in the process to kind of look at the scientific design. And then what happens also is that many times, once a study is, once they've written the protocol and everything has been more solidified, many times the community will also they'll have another meeting to sort of talk about the progress of the study before it actually is before study startup. So again, this is a mechanism that's used quite a bit when we're looking at studies early on in the process in terms of study development. The IRB will sometimes request to have meetings with cultural ambassadors to talk about studies that they're reviewing. And sometimes during the life of a study, when maybe there's going to be an amendment, they will also engage the cultural ambassadors. This last slide is just sort of gives you a sense for how we're doing. So due to all of our efforts, we've been able to really ensure diversity in research studies. And so this last slide indicates that 8% of new patients come to Yale initially for research, but in fiscal year 2020, we found that more than 30% of all accruals across Yale studies included historically underrepresented populations. So I think that's a good number. And I would say that the success of Yale's recruitment efforts, especially in regard to the inclusion of our underrepresented populations in its studies, are really due in large part to Yale's bidirectional and integrated approach that engages community partners, researchers, the IRB, other institutional leaders, and others as part of the process. So with that, I will stop here and turn it back over to Dr. Bussy Jones so we can continue the conversation. Thank you.
Thank you so much. I want to thank you to both of our fantastic speakers. It's really an informative session. And I think that I will just remind everyone to please feel free to submit your questions. I will try to get to as many of them as I can so that we can sort of frame our discussion. And so first, I think the first question that we received was for you, Mr. Ellis, and it talks about, the questioner asked about your comment about minority participants not being asked to participate, and does that literally mean that a Black patient who's in a clinic and eligible for a potential clinical trial is less likely to be approached by the coordinator than a white patient who's seen the same day? They're wondering if an alternative interpretation might be that Blacks are less likely to be at the clinic where recruitment is happening, and whether there is equal access, but there aren't just as many Black patients there. So can you comment on that? Thank you.
You know, that's a very important point when we talk about trying to address some of these challenges in recruitment and retention. I think that what typically happens is the patient population at the institutions are typically not reflective of a diverse population. So many of the benefits of those types of efforts will benefit people who have traditionally benefited from the research. It doesn't really address it. And then when we talk about the efforts to go outside of those walls is what really is going to be important. What we have, there's a body of evidence and literature rather that looks at how those populations that are recruited are conveniently accessible through the practices of the PIs who are a part of the institutions. So short of the kinds of efforts that Linda is talking about, you won't really make any kind of progress trying to think that it can come from the existing patient populations in many of the practices of the PIs and or their colleagues. So it will require this extra effort. So A, to the question, know that those people are not typically in those practices, so they're not asked. But even when they are a part of the practice, some of the things I've mentioned in one of the slides that looked at that how we're not even asked, and how we're seen as difficult patients and difficult subjects, and how we are, the challenges that we tend to represent in the eyes of PIs and researchers override what it would really require for us to really just be a part of the study.
Thank you so much for that response. So it sounds like it's both, really, which is a challenge. So we have to work on our own potential biases around the research participants, but also there may be some other issues as well. Ms. Coleman, I'd like to ask you a question from one of the audience members who asked about the database. Who owns the volunteer database and has access to these profiles? Is it a case by case that's for researchers, and how does that work?
Okay, so it's a Yale New Haven Health System electronic health record. So it's owned by the hospital, but I think I might have mentioned that many of our faculty for School of Medicine have privileges at the hospital, so they would have access to that information as well. What I will say is that that if you are a member of, you're part of this Yale School of Medicine and part of the covered entity, I would say you have access to the information in my chart. But we also have a number of, I call honest brokers, or a group of recruitment specialists that when studies come in, they review the inclusion exclusion criteria, and they actually will run a query so that we're not just going in and having people mine medical records. We're actually trying to provide researchers with a list of research participants that might be eligible for the study. So we try to limit some of the exposure or access as much as we can, while at the same time trying to help promote our researchers. So it's not really one at a time. It's, they do have access to it, but we do have a number of checks and balances in place to try to protect how the information is being accessed.
That sort of leads me to another question, and I'd love to get both of your responses to this question that ask about, usually opt-out approaches appear to violate respect for persons in the assumption that everyone will agree or consent to research, and only dissent, and only with dissent will they be removed. How did the IRB decide on use of an opt-out approach? How did the cultural ambassadors view this approach? And then you, as an ethicist, I would like for perhaps Linda to respond, and then Glenn to sort of comment on that from an ethicist perspective.
I think it's a really good question. I will say the IRB struggled a little bit with it initially, I will say. And I think that's, I will just mention that. And we constantly have those kinds of conversations, and we're trying to assess it. So I think that the way we look at it is, typically we're trying to get information and provide access to people about research. And I think that, once if somebody is approached regarding a potential study, they still have an opportunity to decline. So it's not as though, you're opted in and you're in the study and you're just, you have no opportunity to say, no, I don't want to participate. So I think the way the IRB was able to get around that was with the understanding that it was more that you're going to approach a potential participant to say, this might be something you're interested in. All too often, also, I would want to mention, say, for example, in cancer trials, all too often, as a researcher or as a clinician, you may want to offer a study to someone. So again, you're going to be asked numerous times whether or not you're interested in being in a study. So I think the way they got around it was that piece of it. I think, I don't remember the second question. You asked a second question about the cultural ambassadors. So the cultural ambassador is really interesting. We thought for sure that they might object to this, but in actuality, they feel they feel it's very important, and based on community input, I should say, they felt it was very important that they want to know about the research. And if we had gone the other approach where we're only opting in, it may not have the same effect. And so they thought it was really important to approach it from this perspective.
Well, let me just say a couple things about that from an ethical point of view. I think it's from a pure ethical point of view, it is an extremely paternalistic approach for an institution to make an assumption that, because it definitely challenges and pushes the line when we talk about autonomy. So there was no opportunity for people to decide whether they could weigh in on this decision that they have to opt out instead of making a decision to opt in. So just on a personal level, as an ethicist, I'm an opt-in kind of person. And I think that that holds closest to the spirit of autonomy, that a person should have the right to decide. And opting out assumes that people were adequately notified, that they are adequately understood what their options are. So there are a lot of assumptions being made in order to have an opt-in, an opt-out type of a process when it talks about research or participation in any type of research. So I just think we should also look at that. And I'm just curious, to what extent was the process informed by the community / participants? Or was this, once again, an arbitrary decision made by people making decisions on behalf of a community that they're not a part of? So those are the kinds of issues that are raised in my mind.
And I think those are definitely important issues. And I think that the cultural ambassadors did weigh in quite a bit on the approach in terms of getting feedback from the community. I think what the community wants, the community from what I understood, was they wanted to be a part of the research, to be able to understand what research is available. And I think that there are two aspects to the recruitment strategy. I think the first one is the one where you have media campaigns and you're doing more traditional, like, flyers and radio programs, and that kind of thing. So a fair number of individuals in the community will sign up on their own and set up a profile on their own without actually automatically being opted in. So I think that's an important piece as well. There's definitely an interest there. In regard to the second question about just this concept of engagement enrollment, which is definitely, there's a lot of back and forth on whether we should be opt out or opt in. Again, there was a lot of conversation with the community, a lot of focus groups, a lot of involvement before that practice went into place. And so I think the way that people were able to reconcile that was that you're not necessarily going to use their data. You're not going to be, they're not automatically in a research study. They're just sort of, they're just part of a process whereby they're in a group whereby you may approach them for research that they might be interested in. And as an added protection, rather than having just people mine medical records, which we don't want them to do, is having honest brokers or people who are really highly trained to look at the information before information is provided to researchers. So again, there are a lot of checks and balances put in place to help address it. And there was a lot of community engagement in regard to the process. So it wasn't an arbitrary decision. I will say, though, this is something that we talk about a lot. So it's not like a one and done, where we put this in place in 2010 and we didn't make changes, and they were constantly making refinements, and we could make additional changes along the way if there is sort of opposition.
Yeah, I think I first of all want to make sure that I am very upfront and commending the program and all of the initiatives, because that's really some very unique and remarkable work that's being done at Yale. When you look at the national footprint of what's happening as it relates to addressing issues around equity and inclusion in research. However, I still believe that there are some issues that we can't afford to overlook. And one of the first and foremost ones is that we can't continue or allow ourselves to look at clinical research in a vacuum. Clinical research is a part of a system of that's grounded in structural racism. And so we can't overlook that. So you can't have the ability to look in a vacuum at clinical research and make not arbitrary, but just blanket kinds of decisions about solutions for clinical research that are disconnected from the entire medical experience of the same people. Because the same populations that we're talking about that are not a part of the clinical research are the same populations that don't get the levels of care, don't have access to care, don't have the kind of follow-up. I alluded to some of the algorithms that are used for outpatient care and follow-up care. And we also are talking about people with populations that have a very, very measurable degree of health illiteracy. So the technology around my chart and so many other things around that is so far above. We're right now witnessing the challenges for technology, just trying to, for people around this country to educate their children during this pandemic. And we're seeing the enormous gap in equity as it relates to just access to technology. So so we got to also factor in how much, because a part of bioethics looks at allocation of resources. So are the resources that we're allocating, are we good stewards of the resources? So is there a literacy campaign that we should be considering as opposed to more and more investing in the technology around things like my charts and et cetera? But are we really looking at this to say what's the most ethical way that we can conduct research, which is going to enhance all of the principles of bioethics, from autonomy to non-malfeasance to beneficence and allocation of resources?
So thank you so much. I think that these are really important and probably difficult points. Balancing this great program that has increased minority participation, but really being clear and intentional about the the potential impact and ethical implications of the work that's being done. I think one of the questions kind of carries over from that into the clinical environment. And so someone asked about this idea of automatic enrollment for engagement of patients and how that's addressed even from the clinical standard in the standard consent for hospital care. So when they present to the clinic or the hospital, is this question being, do they know that they're opting in essentially, or the potential to be a part of those things?
So my understanding is that it is sort of front and center along the way. So it's not just at the front door. It is something that you'll see in your My Chart. It pops up. It's very transparent. I mean, I have My Chart as well. So it's very easy to opt out of research if you want to do that, and people do. I mean, I think I didn't share the statistic, but there are a fair number of people who sometimes will choose to opt out. I think that again, I think it's really important. What we spent a lot of time with advertising, with providing information to the community. So it's beyond just this My Chart. So I think that's a really important point that Mr. Ellis, you mentioned, is that some of the work we do, like we do health fairs, there's lots of other things that we engage with the community. So it's not just going to be this one method of recruitment. We really would prefer, and what we want to see is people volunteering, wanting to affirmatively, like, to sign up to do research. And we find that when we engage in other campaigns that are in the community where you're talking with people, they will get excited about research and they want to be a part of it. So for example, with COVID and the vaccine trial, we were talking about this a little bit before the call, there are a lot of people that were, of course they would ask me, are you going to do it? Of course, those kinds of questions do come up. But people really were very excited about doing that. I was very surprised. I thought for sure that people would say, not me, let somebody else do it, and we'll see. So I think it's a combination. I think it's just our recruitment strategy that I described is a snapshot or just a very small sliver of all of the things that we do. And I think that all the points that you raised are very important conversations, and that we have on a regular basis, because we always want to check in to make sure, what are we doing? Are we being too paternalistic? Are we approaching this correctly? Let's really level set. Let's really talk to the community about how they're feeling about it, because we really don't want to violate that principle of respect for persons. That's really, really important to us.
Thank you so much for that. I think that we may have time for one more question. And so this may be one for both of you, which is how you measure success in terms of diversity and inclusion and these recruitment and participation efforts. Clearly, one measure of success might be the number of underrepresented participants. But, you know, as Mr. Ellis described, you know, there are other barometers for what is a successful program. And so I'd pose that question to both of you. What are successes that you would describe when you're talking about research and race?
Well, Linda, would you like to go first, please?
Can we go first? Well, I was just going to say, you know, when I look at those numbers, and I know that's not a good thing to look at, but it's really important to measure what you're doing, to show what's happening. And I think that, you know, to kind of see what's happening there in terms of recruitment numbers, response rates, those kinds of things. I think it's really important. We've learned a lot by doing that. For example, just the idea that people respond to questions regarding research studies or those kinds of things after hours. Like the fact that before everything is done 9 to 5, the fact that we've had to think about, well, maybe we need to do things on weekends and evenings. Those kinds of things are really important in terms of responding to the community's needs. So I kind of look at the numbers and how that would work. But in terms of just general success, I think it really comes down to what I said earlier about the fact that, you know, I know that the opt-out is always a very kind of controversial kind of conversation, but there's a lot of people who just choose to set up a profile and participate in research. And the fact that there are so many people that are calling and interested and wanting to know more, wanting to have training or asking for us or Yale or the cultural ambassadors to go out and talk to them about various issues that are important to them. I think that's the sort of, it's not really, you can't measure it in numbers, but there's this lot of enthusiasm. To me, so that's how I measure success, is that there is a lot of enthusiasm for research in our community.
Well, and for me, I think my barometers are slightly different. I would prefer to focus and look at measurements of success being inclusive of things like the composition of the IRB board, that it should reflect more than just a person or two of color as community representatives. So we really have to do things to structurally change the system to make it more inclusive. That we have to have, you know, more of a reflection of Black and brown principal investigators actually doing research. We have to make sure that we are able to devote the proper amount of resources, time, human and financial resources, to addressing the past wrongs that have been done that have never really been addressed. It's just been left to fester in people's mind, and it's passed down generation to generation. So as a system, we have to do that, because you can't have people who experience implicit bias and racism throughout every aspect of their life. And if you look at the data for maternal mortality, look at birth rates, look at infant mortality, all the way up through death at old age, every experience for most Black and brown people in this country is a negative one that is grounded in racial bias. So what we have to do, my measurements of success, are to see that none of this conversation is ever necessary, that people would understand and be willing and would welcome the opportunity to be a part of research. But the fact that we're still having this conversation in 2020 about how to get more people of color to be involved in clinical research points to the shame and the failure of the research community and of our medical and healthcare system. We spend far too much, almost $4 trillion we're almost up to on an annual basis every year for our healthcare system. And we're still having these kinds of conversations.
Well, first of all, just want to thank you all both so much for this very thought-provoking conversation, where we have heard so much about a really wonderful program that has increased participation of underrepresented research participants, but we've also heard about the ongoing challenges that we've had, not only as a society, but as healthcare systems and research organizations to make things right with our diverse populations. And so with that, I'm going to turn it over to Mary Ellen Morris for our final comments for this session.
Thank you all so much. This was so terrific. We appreciate your time with us this morning and providing your insight. And thank you to everybody who participated in the discussion tab and the questions. A wonderful, wonderful conversation this morning. So we just want to remind folks that we are going to be holding virtual roundtable discussions on the themes presented in today's panel throughout the meeting. So this week's virtual roundtable takes place today at 2:30 p.m. Eastern Time, and it's on the role of IRB and racial bias. Next week on December 8th at the same time, 2:30 p.m. Eastern Time, we'll have another roundtable on community-based participatory research. And in our final week on December 15th, we'll hold another session on diversity, equity, and inclusion in your research compliance programs. And these sessions are really intended for you all to get together and continue the discussion. People will be able to be seen and heard, and we hope you will join us for those events. You can find them on the agenda. Other than that, just a reminder that conference evaluations will be sent at the end of each week, and you can get your certificate of attendance at the conclusion of that evaluation. And session recordings will be made available within about 5 days of session airing. So we really appreciate everybody's time this morning. Again, terrific job from our speakers. Thank